Welcome back to the deep dive. Today, we are putting a specific organ under the microscope. It's an organ that is, well, it's central to mammalian life, it's culturally significant, and clinically. It is a complete minefield of pathology.
It really is.
We are talking about the breast.
And we're going to tackle it by synthesizing two of the real heavy hitters of the field.
Right, we're drawing from Robbins and Cochran pathologic basis of disease and also Underwood's pathology.
It's a fascinating topic because, unlike the heart or the kidneys, which are more or less fully formed functional units when you're born, the breast is it's unfinished business.
Unfinished business, I like that.
It's a dynamic, evolving system that doesn't really finish its development until a woman is in her late teens or maybe even until her first pregnancy.
So it's an organ that's just constantly under construction.
Constantly. And that dynamic nature is exactly where all the trouble starts, isn't it?
It has to be. I mean, if you have a construction site that never truly closes down, eventually someone is going to drop a brook or, misread a blueprint.
Precisely. The central thesis we really need to hold on to today is that breast pathology is largely the cost of doing business for an organ that is constantly growing, shrinking, remodeling.
And just getting battered by hormones.
Yes, responding to hormonal storms. It's a high turnover environment. And in biology, as we know, high turnover equals high risk.
Because every time a cell divides, it's an opportunity for a mistake.
Every single time.
Okay, so before we get into the weeds, let's just hit our standard disclaimer.
Of course.
We are building a conceptual map here. We're synthesizing these incredibly dense chapters to help you, the listener, understand the mechanisms of disease. This is purely for educational purposes.
Right.
If you're a resident or a student, you absolutely still need to read the primary texts. We're trying to be the scaffold. The textbook is the bricks.
Yes. Don't use this deep dive to diagnose your patient's lump, please. Use it to understand why the lump is there in the first place.
Yeah.
We want to give you that framework so that when you open Robbins or Underwood, the details actually stick.
Exactly. So, with that said, let's establish our mission for this dive. If we were to distill these hundreds of pages down, what are the pillars holding up this whole discussion?
I think I see four really distinct pillars.
Okay.
One, the breast is hormonal soil. Every single disease we'll talk about is, in some way, a reaction to the hormonal environment.
The soil. I like that. Okay, what's two?
Two, benign does not mean irrelevant, but you need to understand that most benign lumps are just exaggerated normal responses. They're not necessarily on the path to cancer.
So it's noise versus signal.
A lot of it is noise. Pillar three, breast cancer is not one disease. It's a collection of very distinct molecular entities.
Right, the luminal HER2 triple negative categories.
Exactly. They have different engines.
Yeah.
And we have to treat them differently.
And pillar number four.
Four is a little more for the histology nerds, but honestly, it explains everything clinically. The difference between what we call ductal disease and lobular disease is fundamentally about cellular adhesion.
Cellular adhesion. You mean glue.
It's about glue. If you understand the glue that holds the cells together, you understand how the cancer is going to behave.
I love that. Glue. Okay, let's start with the geography then. If I'm looking at a slide or even just trying to imagine the anatomy, where is ground zero for breast pathology?
Almost everything we care about, good and bad, happens in the TDLU.
The TDLU. Okay, you said that before. That sounds like a government agency. Unpack that acronym for us.
It's the terminal duct lobular unit.
Okay.
Visually imagine a small bunch of grapes.
Got it.
The grapes themselves, those are the lobules, which are just clusters of even smaller sacs called achini. That's where milk is actually produced.
So the lobules are the factories.
They're the factories.
Yeah.
And the tiny little stem connecting that bunch of grapes to the bigger branch, that's the terminal duct.
So the lobule plus its little connecting duct.
That's the unit, the TDLU. It is the functional engine of the breast, and it's where all the hormonal action is. When we talk about fibrocystic change or adenosis or carcinoma, we are almost always talking about something going wrong right there in the TDLU.
And structurally, this isn't just a simple pipe with a single layer of cells, right? This is where that two-cell theory comes in, which Robbins really, really emphasizes.
Yes, and this is absolutely critical for diagnosis. You have to understand this. The ducts and the acini are lined by two distinct layers of cells.
Okay, layer one.
The inner layer, lining the lumen, is the luminal epithelium. These are the workers. They make the milk. They're the ones that, unfortunately, usually turn into cancer.
Okay, so they're the stars of the show. For better or worse, what's the second layer?
But surrounding them, sort of hugging them, is a layer of myoepithelial cells.
Myo, as in muscle.
Exactly. They have contractile proteins. Their day job, so to speak, is to squeeze the acini to eject milk during lactation.
Right.
But their night job, if you will, is to act as the bouncers. They maintain the basement membrane.
The bouncers, I like that.
They keep the luminal cells in check. They send out signals that basically say, stay in your lane, don't break out of this unit.
And this is the fundamental binary distinction in pathology, isn't it? I mean, if the bouncers are there, you're safe.
100%. It's the first thing you look for. If you look at a slide of suspicious lesion and you can identify that outer layer of myoepithelial cells, the lesion is either benign or, at worst, in situ. It is contained.
You can't go anywhere.
It literally cannot travel to another part of the body because it hasn't accessed the highway system, the lymphatics and blood vessels yet.
But the moment you lose that myoepithelial layer?
The moment it's gone, those luminal cells have breached the basement membrane.
Yeah.
The bouncer's been overpowered. Now you have invasive carcinoma.
So myoepithelium equals containment. That's a huge mental anchor for listeners.
That's everything.
Now, what about the dirt these grapes are growing in, the stroma? Robbins makes a distinction here that I think a lot of people might gloss over, but it actually explains a lot of the benign stuff.
They do, and it's crucial because it explains where certain tumors come from. There are two types of stroma.
Okay.
First, you have the interlobular stroma.
Inter, between.
Right. That's the dense, fibrous connective tissue and fat that's between the lobules. It's structural, like the concrete foundation and walls of the building.
Okay, and the second type?
But then you have the intralobular stroma. This is the delicate, loose, specialized tissue that wraps directly around the acini within a single lobule.
Intra, within. And this is the one that's actually listening to the hormones.
It's extremely hormone responsive. It's part of the conversation. And that matters because specific tumors arise from that specific soil.
Ah, okay. So it's not just generic filler tissue.
Not at all. When we talk about fibroadenomas later on, that classic benign lump in young women, that is a tumor of the intralobular stroma.
Which explains why it's so sensitive to the patient's hormonal status.
Exactly. That's why it grows during pregnancy and shrinks at menopause. It's listening to the exact same hormonal signals that the acini are. It's not just scar tissue. It's living reactive tissue.
That's a great distinction. Okay, let's look at the timeline. You mentioned the breast is unfinished at birth. Walk us through the life cycle, because Underwood really suggests this timeline is actually where the risk accumulates over the years.
It is. So it starts at puberty, estrogen comes on the scene, and the rudimentary ducts that are there from birth start to branch like a tree in spring.
But the real drama, you're saying, is the menstrual cycle.
Yes, every single month. We tend to think of the uterus as the main cycling organ, shedding its lining, but the breast is absolutely cycling right along with it.
It's not just sitting there dormant for 3 weeks out of the month.
Not at all. In the second half of the cycle, the luteal phase, say, days 21 to 28, progesterone peaks. This is a powerful signal to the lobules.
And what does it tell them to do?
It tells them to get ready for a potential pregnancy. The cells actually proliferate. There is active mitosis happening.
Wow.
And there's fluid accumulation in that intralobular stroma. This is precisely why many women feel breast fullness or tenderness right before menstruation. The organ is literally gearing up, expanding.
And then menstruation hits, the hormones plummet.
And the whole process reverses. The tissue undergoes apoptosis programmed cell death, the lobules shrink back down, the fluid gets reabsorbed, the scaffolding comes down until next month.
So let me get this straight. Every single month, for decades, the breast ramps up cell division and then has to efficiently kill off all the excess cells.
And that is a biologically dangerous game to play over and over again.
It sounds incredibly risky.
It is. Every time a cell divides, it has to copy 3 billion base pairs of DNA. Every time it does that, there's a risk of a transcription error, a mutation.
And the more you roll the dice?
The more you roll the dice.
Yeah.
So if you have a woman with early menarche and late menopause, she might have 400, maybe 450 cycles in her lifetime.
Compared to someone with fewer.
Right. She is rolling the dice hundreds of more times. That's the basis of the cumulative risk.
This brings us to what you called the grand renovation pregnancy.
Pregnancy is a massive stress test, but it's also the organ's final developmental step. Under the influence of huge amounts of estrogen, progesterone, and prolactin, the lobules expand dramatically.
They must just take over the whole landscape.
They do. They crowd out the stroma. The cells terminally differentiate to become these little milk factories. This is the only time the breast actually achieves its full intended biological potential.
And then after lactation ends, it all has to shut down again.
Right, and that process is called involution. It's another massive scale-down operation involving widespread apoptosis and tissue remodeling. There's some evidence that the inflammatory environment during involution can actually be a temporary risk factor.
Interesting.
But long-term, a full-term pregnancy is protective.
We'll definitely circle back to that protection mechanism later because I know it's nuanced. So finally, we reach menopause.
The hormones stop, the ovaries retire, and the breast follows suit. The lobules atrophy, they wither away. The specialized intralobular stroma disappears and is replaced by fat.
It's the retirement of the tissue.
It is.
Which is paradoxically really helpful for radiologists.
It's the only reason screening mammography works as well as it does in older women.
Why is that?
Because fat is radiolucent. It looks black on an X-ray. Tumors and fibrous tissue are dense. They look white.
So a white tumor and a black, fatty breast
Stands out like a snowball in a coal bin. It's easy to spot.
Whereas in a young woman,
It's the opposite. The breast is full of dense fibrous stroma and active lobules. It's all white on the mammogram. So you're looking for a white tumor in a white background.
you're looking for a polar bear in a blizzard.
Exactly. That's why mammograms aren't generally recommended for women in their 20s, not just because cancer is rare, but because you literally can't see anything. The tissue is too dense.
Okay, so we have the landscape and the timeline. Before we get into the diseases themselves, let's quickly touch on some developmental glitches. The milk line. This sounds like some kind of transit system.
It's an embryology callback. In the embryo, mammary tissue develops along two ridges, the milk lines that run from the axilla, the armpit, all the way down to the groin.
Wow, okay.
Normally, all of that tissue regresses except for the two spots on the chest. But sometimes remnants persist.
So you can have accessory nipples?
Polythelia, yes. Or even chunks of accessory breast tissue anywhere along that line.
So you could technically have a third nipple on your abdomen or your thigh.
Yes, and it's often mistaken for a mole. But the really critical clinical pearl here is something called the axillary tail of Spence.
Right, this isn't an anomaly. This is just normal anatomy. The breast tissue often extends up into the armpit.
Exactly. But it's so important because it means you can get breast cancer in your armpit, completely separate from the main breast mound.
So if a clinician does a breast exam and they forget to check the axilla,
They might miss a primary tumor. It also means that swelling in the armpit isn't always a swollen lymph node. It could just be that person's normal breast tissue, swelling and becoming tender with their menstrual cycle.
that's a great point. What about nipple inversion?
Congenital inversion is pretty common and not a concern, but acquired inversion in an adult,
That's a red flag.
that is a major red flag. It suggests something is growing behind the nipple and pulling it inward. Often that's an underlying carcinoma.
Okay, let's move into the clinic. A patient comes in with a symptom. Help us decode the common presentations. What's a red flag versus what's just noise?
Well, the most common symptom by far is pain or nostalgia. And paradoxically, pain is usually a good sign.
That seems counterintuitive.
It does, but it's usually related to that cyclic edema and stromal swelling we just discussed. It's hormonal. Only about 5% of painful masses turn out to be cancer.
So cancers tend to be stealthy.
Very. They're usually painless. They don't want to alert you to their presence until they're well established.
Okay, what about nipple discharge?
You have to look at the color and the source. Milky discharge, galactorrhea, is almost always hormonal prolactin issues. Maybe a pituitary adenoma, sometimes certain drugs. It's not a cancer sign.
So what is the cancer sign?
The red flag is bloody or serosanguinous discharge, especially if it's coming from a single duct,
Why a single duct?
because it implies a focal lesion. Something is growing inside that one specific duct, and it's fragile. It's tearing up the local blood supply.
And that something could be.
It could be a benign papilloma, which is common, but it absolutely demands a workup for carcinoma.
Got it. And finally, the palpable mass, the lump.
The feel of the lump tells you a lot. A benign lesion, like a fibroadenoma or a simple cyst, is usually smooth, round, and mobile.
It rolls under your fingers.
Right, it's encapsulated, it's not stuck to anything. A malignancy, on the other hand, is invasive. It sends out these little tentacles that grab onto the surrounding stroma and fat.
So it feels fixed.
It feels fixed, hard, and tethered. It has irregular borders. It feels like a rock that's been frozen in a block of ice. And that pulling, that tethering, is why you sometimes see dinkling of the overlying skin.
Okay, this is a great clinical framework. Let's dive into section 3 now. The benign epithelial lesions. Robbins classifies these into 3 buckets based on cancer risk, which seems like the most practical way to think about them.
It is. This is how you have to categorize them in your mind. Is this non-proliferative? Is it proliferative without atypia? Or is it proliferative with atypia? The answer determines whether you tell a patient, this is fine, see you in a year, or we need to talk seriously about your risk.
Okay, so let's start with bucket 1, non-proliferative breast changes. We used to call this fibrocystic disease, right?
We did, and we've purposefully moved away from the word disease.
Why is that?
Because it's so incredibly common, affecting more than half of women, that it's essentially a variant of normal physiology. It's not a disease. It's an exaggerated response.
And this bucket includes things like cysts and fibrosis. Mechanistically, what is a cyst? What's happening there?
It goes back to that TDLU expanding and contracting with the cycle. Sometimes a lobule expands, but then it doesn't get the signal to involute properly, or a duct gets obstructed.
So it just stays dilated.
It stays dilated and fills with fluid. That's a cyst. Sometimes they can get large and group together, and on gross examination, they might have this translucent, cloudy fluid that looks blue.
The famous blue dome cysts?
That's the one. The key is that these cysts can rupture. The fluid spills into the stroma. The stroma doesn't like that and reacts with chronic inflammation, which eventually leads to scar tissue.
Which is the fibrosis part of fibrocystic change.
Right. And that's what makes the breast feel firm, dense, and lumpy to the patient and the doctor.
And the most important question, what is the risk of cancer here?
0 or negligible. No significant increase in risk. This is strictly noise in the system. It can cause symptoms, but it's not a precursor to malignancy.
Great. Let's move to bucket 2, proliferative breast disease without atypia.
Okay, now we're taking the risk up just a little bit. Here, we have cells that are actually dividing more than they should be.
But they still look normal.
They still look normal. They're polite. They haven't become atypical yet. The classic example is epithelial hyperplasia.
Explain that.
So a normal duct has 2 layers, right? The interluminal and the outer myoepithelial. In hyperplasia, you have more than 2 layers piling up, 3, 4, 5 layers filling the ductal space. But the cells themselves look benign.
Okay, now there's a specific entity in this category called sclerosing adenosis that I find fascinating because it's such a great mimic of cancer.
It is a radiologist's nightmare. It's a 2-part process. Adenosis means you have an increased number of acini within the lobules. They're proliferating.
More grapes in the bunch.
More grapes in the bunch. But at the same time, you get sclerosis, which is fibrosis in the stroma that squeezes and compresses those proliferating acini.
So it distorts the architecture.
Completely. And crucially, these areas often develop microcalcifications. So what do you see on a mammogram? A hard, spiculated, calcified mass.
It looks exactly like cancer.
It can be indistinguishable from an invasive carcinoma. You have to biopsy it to prove it's benign.
But biologically, even though it looks bad, it's not truly precancerous.
It carries a small but real increased risk, about 1.5 to 2 times the risk of the general population. It tells you that the breast tissue is excitable or unstable, but it's not considered a direct precursor lesion.
Okay. Now for bucket 3. Proliferative disease with atypia. This is the danger zone.
This is the danger zone. Now we're talking about atypical ductal hyperplasia, ADH, or atypical lobular hyperplasia, ALH.
The word atypical is doing a lot of heavy lifting there.
It is. It means the cells are starting to look bad. They're monotonous. They're clonal. They share some of the same genetic mutations that we see in carcinoma in situ.
So how close is something like ADH to actual ductal carcinoma in situ, or DCIS?
Morphologically, under the microscope, they can look identical. The cells look the same. The only difference is quantitative. It's about size and extent.
How so?
If the atypical proliferation is small and only partially fills the ductal spaces, we call it ADH. If it grows larger and fills up entire ductal units, we reclassify it as low-grade DCIS.
So it's essentially pre-cancer. It's one step away from being called carcinoma in situ.
That's a great way to put it. It's a direct, albeit low-grade precursor.
And the risk profile reflects that.
It does. A diagnosis of atypical hyperplasia carries a moderately increased risk of subsequent invasive cancer, about 4 to 5 times the general population's risk.
So this is where you start having serious conversations with the patient.
Yes. This is where we start talking about risk-reducing medications like tamoxifen, or at the very least, much more aggressive screening with mammograms and MRIs. The patient has entered a different category of surveillance.
Okay, let's switch tissue types for a moment. We talked about that special hormone-sensitive intralobular stroma. What happens when that tissue decides to form a tumor?
Then you get a fibroadenoma. This is the single most common benign tumor of the breast, especially in young women, in their 20s and 30s.
And you said before it's biphasic. What does that mean?
It means it's a tumor of two components. You see a proliferation of both the stroma, the intralobular stroma, and the epithelium of the glands.
So both parts are growing.
Yes, but the stroma is really the driver. It grows and expands, and in doing so, it compresses the epithelial ducts into these long, slit-like spaces.
And why is it famously called the breast mouse?
Because of how it feels on clinical exam.
Yeah.
It's so well-defined, so encapsulated and rubbery, that when you try to palpate it, it's slippery. It shoots away from under your finger.
Right, to catch a mouse.
Exactly. It tells you it's not tethered to the surrounding tissue, which is a very reassuring sign.
And because it arises from that specific hormone-sensitive stroma?
It tracks the patient's life cycle perfectly. It responds to estrogen. It can grow noticeably during pregnancy or with oral contraceptive use.
And after menopause?
It tends to regress, shrink, and often calcifies, becoming this dense popcorn calcification on a mammogram.
Now, there is a darker, more aggressive cousin to the fibroadenoma, the Phyllodes tumor.
There is. Phyllodes comes from the Greek word for leaf-like.
Why leaf-like?
Because these tumors also start in the intralobular stroma. But the stromal cells are much more cellular and aggressive. They grow rapidly and form these bulbous, leaf-like projections that push into cystic spaces. It's a much more exuberant growth pattern than a fibroadenoma.
And are they malignant?
It's spectrum. Most are benign, but some are classified as borderline and others are frankly malignant.
And the malignant ones can be dangerous.
They can. They have a tendency to recur locally if they're not fully excised, and the malignant ones can metastasize through the bloodstream, which is different from typical breast cancers that prefer lymphatics.
So how do you tell them apart?
The key distinction from a fibroadenoma is the cellularity of the stroma. In a Phyllodes tumor, the stroma is packed with cells, and you see a much higher mitotic rate. If a fibroadenoma is a polite gathering, a Phyllodes tumor is a riot.
Let's talk about inflammation. The breast is effectively a modified skin gland, a sweat gland, so it's prone to the same kinds of infections.
It is, and acute mastitis is the big one. This is almost exclusively a disease of lactation, usually in the first month of breastfeeding.
What's the mechanism? How does the bacteria get in?
It's all about mechanical trauma. The baby nursing can cause small fissures or cracks in the nipple. That creates a portal of entry for skin flora.
And the usual culprit is?
Staphylococcus aureus. Staph loves to get in there, and it's pyogenic. It makes pus. So you get a localized, very painful, red-hot abscess.
And the treatment isn't just antibiotics, right? You have to do more.
Right. You need drainage of the abscess, but critically, you have to encourage the patient to keep breastfeeding or pumping. Stagnant milk is a perfect culture medium, a petri dish. You have to keep the milk flowing to clear the infection.
That's a really important clinical point. But there's another inflammatory condition that has a really specific, almost detective story-like mechanism involving smoking.
Ah, yes. Zuska disease, or more formally, squamous metaplasia of the lactiferous ducts.
It has a very strong link to smoking.
Over 90% of cases are in smokers.
Yeah.
And the mechanism is just beautiful pathology.
Okay, lay it out for us.
So normally the large ducts right under the nipple are lined by a specialized glandular or lactiferous epithelium. To maintain that specialized lining, the cells require a steady supply of vitamin A.
Okay, so vitamin A is the maintenance signal, stay as a ductal cell.
Exactly. But we know that toxins in tobacco smoke interfere with vitamin A metabolism locally in the breast tissue. So in heavy smokers, that duct lining becomes relatively vitamin A deficient.
And the cells respond to that deficiency.
They respond by changing their identity. They undergo metaplasia. They transform from glandular ductal cells into squamous cells, basically skin cells.
And skin cells make and shed keratin.
Precisely. On the outside of your body, you shed keratin flakes into the air. But inside a closed duct, that keratin has nowhere to go. It builds up and forms a plug.
So the duct gets blocked?
The duct gets blocked, it dilates, it can rupture, and the body has a violent inflammatory reaction to keratin being spilled into the stroma.
So that's what causes the abscess.
That's what causes the chronic, recurring, painful subareolar abscess. And you can drain it, you can give antibiotics, but unless the patient stops smoking or you surgically excise that entire diseased duct system, it'll just keep coming back.
That is a fantastic clinical pearl. Smoking leads to vitamin A deficiency, leads to metaplasia, leads to a keratin plug, leads to a recurring abscess.
It connects perfectly.
Another mimic we need to mention is fat necrosis. This is usually caused by trauma.
Yes, a seatbelt injury in a car accident, a blow to the chest during sports, even a surgical procedure.
And why is it a mimic of cancer?
Because the end result looks just like it. When the fat cells die, they rupture and release their lipid contents. This triggers a huge inflammatory response. Macrophages rush in to clean up the mess.
And what do they do?
They eat the fat and become these foamy, lipid-laden macrophages. Eventually, the area heals with scar tissue fibrosis, and it often develops dystrophic calcifications.
So clinically and radiologically?
You have a hard, painless, sometimes skin-tethered calcified mass. It can look identical to cancer on a physical exam and on a mammogram.
So that history of I got hit in the chest with the softball a few months ago is actually incredibly relevant.
It is, though you still almost always have to biopsy it to be 100% sure. You can't just assume.
All right, we're at the main event, malignancy. But first, the precursors. Carcinoma in situ, we defined this earlier. The bouncers, the myoepithelial cells, are still present. The basement membrane is intact.
Which means, by definition, metastasis is impossible. The cells have not reached the blood vessels or the lymphatics yet.
It's like a criminal gang that has taken over the house but hasn't left the property.
Perfect analogy. They are contained.
Okay, let's distinguish the two main types. Ductal carcinoma in situ, DCIS, versus lobular carcinoma in situ, LCIS. Let's start with DCIS. This is the one we usually find on mammograms. Why?
It's all about how it grows. DCIS cells proliferate, and they pack the duct tightly. As they grow and fill up the duct, the cells in the very center get too far away from the blood supply, which is in the stroma outside the duct.
So they starve.
They starve and they die. This central necrosis is called comedo-necrosis because it can look like a cumbin or a pimple on gross inspection. And that area of dead necrotic debris is a perfect site for calcium to deposit.
And those are the calcifications that light up on the mammogram.
Exactly. You see these linear, branching, casting microcalcifications that follow the path of the ductal system. It's the tumor leaving a trail of breadcrumbs for the radiologist to find.
And if we just left DCIS alone, what would happen?
It's a true, direct precursor. The data suggests that if left completely untreated, about 1/3 of cases will progress to invasive ductal carcinoma over a period of years.
And usually in the same spot.
Usually in the same breast and often in the same quadrant. It's the waiting room for invasive cancer.
There's also a specific clinical presentation of DCIS called Paget disease of the nipple.
Yes, this is fascinating. This happens when the DCIS cells don't just stay inside the duct, but they migrate. They crawl up the ductal system all the way to the surface skin of the nipple and areola.
Yes, they just follow the pipe to the exit.
They do. And once on the skin, they disrupt the normal skin barrier, causing an eczematous, crusted, scaly, sometimes ulcerated rash.
So a unilateral nipple eczema in an adult is a major, major red flag.
It should be considered underlying breast carcinoma until proven otherwise.
Now let's contrast all of that with LCIS, lobular carcinoma in situ.
LCIS is a totally different beast. It's the silent one. It rarely forms a mass. It almost never calcifies.
So how do we even find it?
We usually find it by accident. It's an incidental finding when a biopsy is done for some other reason, like a fibroadenoma or a suspicious mammographic density.
And the biology here is completely distinct. It comes back to your glue story.
It's all about the glue, the E-cadherin story. E-cadherin is a transmembrane protein that acts as the molecular glue, holding epithelial cells tightly together.
And in lobular neoplasia,
there is a characteristic mutation in the CDH1 gene that inactivates or destroys the E-cadherin protein.
So the cells don't stick to each other.
They don't. They become discohesive. They just float around loosely inside the acini, filling and expanding them, but not forming a solid structure.
Which is why they don't cause necrosis and calcification.
Exactly. There's no solid core to outgrow its blood supply. They're just loose cells filling the space.
And because of this different biology, its clinical implication, its risk profile is weirdly systemic.
It is. This is a crucial point. We no longer view LCIS as a direct precursor that's going to turn into cancer right there. We view it as a marker of global bilateral risk.
So if you find LCIS in the left breast,
your patient's risk of developing an invasive cancer is significantly elevated, but that cancer could arise in either breast. It could be ductal or lobular. It just tells you that the entire field of breast tissue on both sides is unstable and at high risk.
That completely changes the management discussion. You can't just tell the patient, we cut it out, we got it. The risk is biological, not just geographical.
Exactly.
Okay, Section 7, invasive carcinoma. The basement membrane is breached, the bouncers are gone, the gang has left the house.
Now, the malignant cells can access the lymphatics, usually spreading to the axillary lymph nodes first, and the bloodstream. The game is completely changed. This is now a potentially systemic disease.
We categorize these cancers by their shape, their morphology, and by their engine, their molecular profile. Let's start with shape. The most common one is no special type, or NST.
Right, which used to be called invasive ductal carcinoma, NOS, not otherwise specified. This is the classic garden variety breast cancer, about 75% of all cases.
And these are the ones that form those hard, rock-like tumors.
They are. And that hardness comes from a process called desmoplasia. The tumor cells invade the stroma and provoke a massive fibrotic reaction. It's like the tumor is building a fortress of scar tissue around itself as it grows.
Okay, now what about invasive lobular carcinoma?
We're back to the ECAD-heron mutation, back to the lack of glue.
So because these cells don't stick together, they don't form a big, round, desmoplastic ball.
They don't. They infiltrate the tissue in a much more insidious way. They sneak through the stroma in single-file lines. Pathologists call this classic pattern Indian filing.
That sounds incredibly stealthy.
It is. They don't destroy the normal tissue architecture. They just move between the native collagen fibers. And because of this, they often don't form a discrete, palpable lump. The breast might just feel vaguely thick or dense.
Which must make them incredibly difficult to detect.
Notoriously difficult. They're very hard to see on mammograms and often difficult to feel on physical exam until they are quite large. They're the ninjas of breast pathology.
Okay, but the real revolution in how we understand and treat breast cancer hasn't come from looking at shapes under a microscope. It's come from looking at receptors, the molecular subtypes.
This is the absolute standard of care now. We treat the biology, not just the anatomy. When a breast cancer is diagnosed, the pathologist must test it for 3 key markers.
The big 3.
The estrogen receptor, ER, the progesterone receptor, PR, and a protein called HER2.
Let's break down the 3 major groups that come out of this testing. Group 1, luminal.
These are cancers that are ER positive, meaning they have the estrogen receptor. They're called luminal because their gene expression profile looks similar to the normal luminal cells that line the ducts. This is the most common type by far.
And because they have the estrogen receptor, they depend on estrogen to grow.
They do. Estrogen is their fuel. And that gives us a perfect target. We can use anti-estrogen therapy drugs like tamoxifen or aromatase inhibitors to starve the tumor of the fuel it needs to survive and proliferate.
Which generally means they have a better prognosis.
Generally, yes. Within this group, we can further subdivide into luminal A, which are slower growing, and luminal B, which are faster growing. But the key principle is that they are hormone-driven and hormone-treatable.
Okay. Group 2, HER2 positive.
HER2 is a growth factor receptor that sits on the cell surface. Think of it like an antenna that receives signals telling the cell to grow and divide.
And in these cancers,
The HER2 gene is amplified. The cell makes millions of copies of this gene, so the cell surface becomes covered in these antennae. It's getting a constant screaming, grow, grow, grow signal, even with no actual growth factor present.
historically, that was very bad news.
It was a death sentence.
Yeah.
These were some of the most aggressive, fast-growing tumors with the worst outcomes. But then a true game changer was developed, trastuzumab, brand name Herceptin.
The targeted therapy.
It's a monoclonal antibody that specifically binds to the HER2 receptor on the outside of the cancer cell. It blocks the signal, and it also flags the cell for destruction by the immune system.
And it transformed the prognosis.
It turned one of the deadliest forms of breast cancer into one of the most treatable. It is one of the greatest success stories in modern oncology. And it fundamentally proves the value of understanding the specific molecular mechanism driving a cancer.
It's precision medicine in action.
Absolutely.
And that leaves the difficult one. Group 3, triple negative.
ER negative, PR negative, and HER2 negative.
It has none of the targets.
None of the big 3. You can't starve it of estrogen. You can't block the HER2 receptor. It's running on a different kind of engine, one we haven't figured out how to switch off with a targeted drug yet.
So how do you treat it?
You have to fall back on traditional cytotoxic chemotherapy. You just have to poison all rapidly dividing cells and hope you kill more cancer cells than normal cells.
And what's the profile of these tumors?
They tend to be very high grade and aggressive. They often affect younger women, and they are very strongly associated with inherited BRCA1 mutations. This is the area where we desperately need new therapeutic breakthroughs.
Let's talk more about those risk factors. Section 8, we touched on it earlier, the estrogen hypothesis.
It really is a cumulative math problem.
Hmm.
Estrogen, particularly unopposed by progesterone, stimulates breast cell proliferation. The more total lifetime exposure to estrogen, the more proliferation, the more chances for mutation.
So things that increase the number of cycles matter?
Absolutely. Early menarches, starting your periods young, plus late menopause, stopping them late, equals the maximum number of cycles. That's a major risk factor. Nulliparity, or never having a pregnancy, is also a risk because you never have that 9-month break from cycling.
What about obesity?
Obesity is a huge risk factor, particularly in postmenopausal women.
Why postmenopausal specifically?
Because once the ovaries shut down, the main source of estrogen in the body is from peripheral conversion in body fat. Fat cells contain an enzyme called aromatase.
Right.
Aromatase takes androgens made by the adrenal glands and converts them into estrogen. So excess adipose tissue basically acts as a distributed estrogen factory, bathing the body in low levels of estrogen long after menopause.
So losing weight after menopause isn't just for heart health, it's an actual cancer prevention strategy.
A very effective one. It directly lowers the systemic estrogen load.
And what about pregnancy? We said earlier it's protective, but it's complicated.
It is, and the timing is everything. A full-term pregnancy, particularly an early one, induces the terminal differentiation of the luminal cells in the TDLU.
They grow up.
They grow up. They become specialized, mature, milk-producing cells. And terminally differentiated cells are much less likely to mutate and become cancerous than more primitive stem-like cells.
There's a catch.
The catch is that this protection really only works well if the first pregnancy occurs early, say before age 30 or 35. If you delay that first pregnancy until after age 35, the protective effect is lost and may even be slightly reversed.
Why would that be?
The theory is that by age 35, those undifferentiated cells have already been cycling for 2 decades and have accumulated a certain number of DNA hits or mutations. Forcing them to differentiate after the damage is done doesn't help. It might even lock in those mutations.
That is a very sobering thought, especially given modern demographics and women delaying childbirth.
It is.
Finally, let's touch on genetics. BRCA.
We talk about BRCA a lot, and it's incredibly important for the families that carry it. But we have to remember, only about 5 to 10% of all breast cancers are related to a strong inherited genetic predisposition. Most are sporadic.
Right.
But for those families, it's devastating. BRCA1 and BRCA2 are tumor suppressor genes. Their normal job is to be part of the DNA repair crew.
They fix mistakes.
They fix mistakes. If you are born with a broken copy of one of those genes, your repair kit is faulty from day one. You can't efficiently fix the daily DNA damage that occurs in your cells, so mutations accumulate much faster.
And there's a distinction, right? BRCA1 is more linked to...
The triple-negative cancers we just discussed, and also ovarian cancer.
And BRCA2?
BRCA2 is more often linked to ER-positive cancers, and very importantly, to male breast cancer.
Right. We almost always forget that men can get breast cancer.
They can. Men have the large ducts under the nipple, but they usually lack the developed globules, so men can get breast cancer. And it's usually ductal and ER-positive.
And is it more dangerous in men?
It tends to present at a later stage. Because men have so little breast tissue, there's no cushion. The tumor's right up against the skin and the chest wall muscle. It invades those structures much earlier.
So, to synthesize this entire deep dive, we have an organ that is designed for flux. It's built to change. And all of its pathology is essentially the breakdown of the regulatory systems that govern that change.
That's a perfect summary.
It's too much growth signal, like in HER2 positive cancer, or it's a lost adhesion signal, like the E-cadherin loss in lobular cancer, or it's a failure to properly clean up after the party, like some of the issues with involution.
Exactly. We've moved from just seeing a lump to seeing a specific molecular accident occurring in a very dynamic, hormonally driven ecosystem. It's about the soil, the seed, and the weather all coming together.
I have a final thought for the listener to chew on, something that synthesizes everything we've said.
Go.
We talked about how the breast is the only organ that isn't fully formed at birth. It relies on the external environment, on hormones, on pregnancy, to complete its development. In a way, it's the most modern organ we have, constantly interacting with our lifestyle choices and societal shifts.
That's an interesting way to frame it.
So if the biological window for that protective differentiation that comes with pregnancy starts to close in our late 20s, but modern society, for very good reasons, pushes childbirth into our 30s or 40s, we are effectively living in a biological mismatch.
A conflict.
We're running Paleolithic software in a modern world, And the breast tissue is bearing the brunt of that discrepancy.
That is the fundamental tension of modern breast pathology. Biology versus biography. A perfect place to end.
If you really want to see the Indian filing of lobular carcinoma or the leaf-like architecture of a Phyllodes tumor, grab your copy of Robbins or Underwood. The visuals really do cement these concepts.
Highly recommended. The pictures are worth 1,000 words.
Thanks for diving deep with us.
My pleasure. See you next time.